are pivoting to H202. Specifically, there's two sections in 202 that I thought would be helpful for us to get a walkthrough on from Ledge Council as they pertain to 340B and reporting type things. So, thank you.
Sure. Good morning, Jen Carby from the Office of Legislative Counsel. And we'll put this language up. So this is H202. It's an act relating to increasing the transparency of prescription drug costs and spending. It sounds like we will skip sections 1 and 2 for now and just look at sections 3 and 4.
Yep.
Okay, so section 3 would add a new provision in Title 18 on reporting on participation in the 340B drug pricing program. It would require annually on or before July 1st that each hospital that participates in the federal 340B drug pricing program submit to the Green Mountain Care Board a report detailing the hospital's participation in the program during the previous calendar year. And the board would have to post that report on its website. The report would need to contain at least the following information. First, the aggregated acquisition cost for all prescription drugs that the hospital obtained through the 340B program during the previous calendar year. The aggregated amount that the hospital received for all prescription drugs obtained under the 340B program and dispensed to patients during the previous calendar year. The aggregated payment amount that the hospital made to pharmacies with which the hospital contracted, so 340B contract pharmacies from our discussion yesterday, to dispense drugs to its patients under the 340B program during the previous calendar year. The aggregated amount that the hospital made to any other outside vendor for managing, administering, or facilitating any aspect of its 340B drug program during the previous calendar year. All other expenses related to administering the 340B program, including staffing, operational, and administrative expenses during the previous calendar year. The names of all vendors, including split billing vendors, contract pharmacies, and pharmacy benefit managers with which the hospital contracted to provide services associated with its 340B program participation during the previous calendar year.
Can I interrupt real quick?
Yeah.
What's a split billing vendor?
I'll let somebody else tell you that. I don't.
Okay. Okay.
It's not a term I know either. The number of claims for all prescription drugs the hospital obtained through the 340B program during the previous calendar year, including the total number of claims and the number of claims reported separately by payer type, including Medicare, private insurance, and uninsured. A description of the ways in which the hospital uses savings from its participation in the 340B program to benefit its community through programs and services funded in whole or in part by savings from the 340B program, including services that support community access to care that the hospital could not continue without these savings. A description of the hospital's internal review and oversight of its participation in the 340B program in compliance with, you heard about HRSA yesterday. It's the U.S. Department of Health and Human Services, Health Resource and Services Administration, and they have 340B program rules and guidance. And finally, such additional information as the board may request. So that would all be posted on the Green Mountain Care Board's website for each hospital that participates. I believe it's all of our hospitals. Section 4 is another new section in the same chapter and subchapter in Title 18 on annual prescription drug disclosures to consumers. So there's a few different parts. First, annually within 6 months following the end of the plan year, a health insurer would have to provide to each individual covered under a plan offered or administered by the insurer a report of the total amount that the plan actually spent on prescription drugs for or on behalf of the covered individual during the previous plan year, net of all rebates and discounts, so the actual drug spend. The health insurer shall send the prescription drug spending report to the covered individual at the same address to which the insurer sends the covered individual's explanation of benefits. Some privacy provisions in case there is a different address that somebody is receiving explanation of benefits at than perhaps the one for the main policyholder. Also annually on or before March 1st, each covered entity participating in the federal 340B drug pricing program shall notify its patients if one or more of the prescription drugs prescribed for that patient by a healthcare professional affiliated with the covered entity was purchased through the 340B program. And for a covered entity that is a hospital, the notice must include information about how to access the report on the Green Mountain Care Board's website that was in the previous section, including the ways in which the hospital uses savings from its participation in the program to benefit its community. And that's it. The act would take effect on July 1st with the first hospital reports to the Green Mountain Care Board about their 340B participation due on or before July 1st of 2026.
Leslie?
That's your
Question?
Sorry, I shut up. I'm just wondering how P66 and 202 kind of intersect. And I'm not that familiar with those, so if it's obvious, I'm sorry.
But I think they're both relating to 340B drug pricing. Section 266 is looking at practices, manufacturers and payers practices with respect to participants in the 340B program. This would be having the participants doing some reporting on their participation.
So there's no reason to have them together or in one.
I think that's a committee prerogative to talk about.
Right, so
Okay.
it's up to the committee.
Okay, I just want to make sure I'm understanding.
Right, I mean, we're looking at the two bills that specifically address 340B
Put it in.
and the committee can decide whether there are any parts of either or both you want to move forward.
Thank you.
On page 6, line 12, that whole piece, there's no requirement that the covered entity that participates in the 340B has to tell a patient how much they acquired the drug for. Is there, I mean,
No,
it just has to say you were prescribed a drug and it was purchased through 340B program.
Yes, one or more of the drugs prescribed for you was purchased through the 340B program. And if it's a hospital, they would say, and here's how to learn more about our participation in 340B on the Green Mountain Care Board's website.
Is there any specific reason why this is, it appears anyway, I could be wrong, to be dealing just with the hospital?
Section 3 is just on the hospital. And you may want to ask the proposers of the bill, the rationale there. I think some of it was the effort involved in reporting and whether you wanted FQHCs and others to be going through that effort. But the lead sponsors.
Did you? Yeah.
No, actually, I'm thinking about the rest of the bill. Will we have a chance to do a read through of the whole bill?
We will.
Okay. I know this is just related.
Yeah, I just
What we're
wanted
talking
to
about
put this on
today.
the table in case it fit into the other.
Yeah.
This is actually just for my knowledge that, is there something in the statute regard, because it's required that payers send explanation of benefits. Is there something that exempts prescription drugs from having to send an explanation of benefits? Why are they not doing that now, I guess is my.
I don't believe it's a statutory requirement that they send explanation of benefits. That may be it may just be a practice or a DFR requirement. I don't think the statute itself speaks to explanation of benefits.
I thought that insurers had to, okay, maybe.
I think there a requirement exists somewhere. It is not, to my knowledge, a statutory requirement.
Okay, thank you. All right, Woody, yeah.
It just seems, there's probably a reason behind this, but it seems like there's a lot of administrative requirements for hospitals to do this work. I'm wondering, how much time and effort a hospital will have to take to do this, particularly when we're trying to reduce administrative costs for our healthcare, and it just seems like we're adding more requirements on them, and perhaps there's a necessity behind it, but that's just what I'm seeing with this.
So you're speaking specifically about section 4?
Well, I'm speaking about section 3 as well. And here again, with the Green Mountain Care Board, how much time and effort are they going to have to be required to work on this? Just my thoughts.
I think next up we have Catherine O'Neill from Green Mountain Care Board, so let's talk to her about that.
Good morning. Are you able to hear and see me all right?
Yep.
Great. Good morning. Thank you for the opportunity to talk with you this morning, specifically on Section 3 of the bill. I am Catherine O'Neill, Director of Prescription Drug Pricing at the Green Mountain Care Board. And on screen here with me today is Noah Montemorano. He's a policy analyst at Green Mountain Care Board. We're working together on understanding prescription drug pricing, specifically to Act 134, which was passed last year. So we're here this morning with a few general comments, specifically to Section 3, and then we'll summarize that here. And then we have some recommendations on a few of the subsections in this section. As a follow-up, later today, we'll provide these in written comments back to the committee. So hospitals do report some aggregate 340B data already to the Green Mountain Care Board as part of their annual submissions. This bill would expand on that reporting. We do think it would be helpful to specify the purpose for this additional reporting, whether it's to better understand how hospitals use the 340B revenues to fund other hospital operations or services, or to better understand the impact of the 340B program on the insurance plans, maybe to better understand the cumulative impact of the 340B program on patient cost sharing, or maybe there's another goal that the committee has or that this bill is looking to accomplish. We do think that the wording in this section doesn't appear to violate federal 340B rules or confidentiality. We do want to say, though, that if the Green Mountain Care Board were to be collecting and posting these data to the website, we'd like to suggest adding something along the lines of subject to the Public Records Act, just to ensure that release of any required submissions are aligned there. We recommend including a requirement that hospitals attest or certify that the information provided is true and accurate. And it wasn't clear to us in this bill whether the submission of the information, which would be due annually on or before July 1st, is intended to be done along with or as part of the annual hospital budget and required documentation submission to the Green Mountain Care Board, which is part of the hospital budget review process. We get that this could certainly serve to streamline submission, but important to understand that Green Mountain Care Board doesn't regulate on specific line items in a hospital budget. So if in the future state law were to require that we do more with the 340B data than just to collect it for transparency purposes, say if the legislature wanted to use the data as basis for regulation, we'd have to do that outside of the hospital budget process. And then the final general comment on this section is related to staffing. If the required reporting submitted by the hospitals annually is just to post it to the Green Mountain Care Board website for added transparency, that wouldn't require much in the way of staff effort. But if we were to need to do additional analysis of the data collected pursuant to this bill, that would increase the required level of effort. We'd have to discuss that in addition separately. We have a few comments specific to some of the subsections, specifically section 2, 4, 7, and 8. So shall I jump right into that?
We did section 2, we did not do any walkthrough of
Sorry,
section
in
2.
section 3, but
Oh,
but
section
the
3.
yeah, but the subsections, the
Oh, do you have the
That's what I
page?
mean.
Do you have the
Am I
page
saying
and
it
the
right?
line? Do you have the page number and the line?
Oh, I'm not looking at the bill that way. Sorry.
Oh. All
What
right,
section is she? What
It's
section
set-
are you looking at?
section
So I'm in
3.
section 3, the reporting on participation in the 340B pricing program. And then number 2, the aggregated payment amount that the hospital receives for all prescription drugs obtained under the 340B program.
That's line 10.
Page 4, line 12.
Thank you. Our comment there is related to the collecting the total payment amount that the hospital receives. We'd recommend including patient cost sharing in the total amount so that we can more fully see the value of the 340B program and distinguishing between the total amount reimbursed by insurance companies versus the total amount reimbursed by patient cost sharing. That's just additional, a deeper layer of reporting and understanding on that. On line 4, I'm not sure what number that or what line that is, but that subsection 4 related to
18.
the negotiated payments to vendors. We just thought that it's possible that a hospital might argue that their negotiated payments constitute trade secret and would warrant confidentiality. Just a comment here, we thought if we agreed with their assessment, we wouldn't be able to post this data publicly. We'd only be able to publish it in more of an aggregate, like a combined total expenses, which would combine 4 and 5. On subsection 7 related to reporting the number of claims that the hospital obtained through the 340B program, we suggest including also reporting 340B claims as a percentage of all claims. This is going to help us to better see the scope of the 340B program. And then on subsection 8, which is related to providing a description of the ways in which hospitals use the 340B revenues, we just want to say that while it can be referred to as savings, and we do hear that. We heard it yesterday in the testimony that you received yesterday, here and there. It's not actually savings, so we just want to point that out. It's revenue or profits because it's generated from the resale. It's dollars generated from the resale of drugs purchased at a discount from the manufacturers. So for clarity, we'd recommend considering using terminology other than savings. We'd also recommend adding a listing of the community programs, the total cost of each program in that year, and the percentage of the programs supported by 340B revenue. And finally, suggest requiring hospitals to provide detailed and quantitative data to support any claims that services that support community access to care would not be able to continue without 340B revenue. And we say this because without evidence, it would just be storytelling and it wouldn't have much value, and it would be added burden for busy work. So that's it for our comments. Thank you again for the opportunity to provide input, and I'll give it back to you, Chair Black.
Great. Any questions for Catherine?
Yeah, go ahead. This in writing.
Yeah, she's going to send us in writing this afternoon.
Not trusting my notes.
Yeah. I currently right now within the hospital budget review process.
11:24 a.m.
Thank you, Tapper.
Right on time, Topper.
Your watch.
That's why I don't wear it.
Apparently he's telling me to get a move on. So currently in the current hospital budget review process, do hospitals report any type of data around their revenue from 340B?
I can
Do
take this if you
use
want.
an aggregate. Oh, I'm sorry. No, I'm talking over you. I was going to say yes, they do. I would like to turn it over to Noah for more specifics. He worked on the hospital budget review process last year, so I think he knows a little bit more about that.
That's
Sure.
great.
Yeah, I apologize if there's a lag. Just let me know if I'm accidentally interrupting anybody. Yes, so for each hospital, we collect total revenue. That's all. So on their income statement, on their income sheet, there's one line designated for 340B revenue. And so we have a just lump sum value for each hospital. Some hospitals in their narratives detail pharmaceutical expenses, and some of them get into 340B expenses, some of them don't. It's not standardized. But
Do they
that's
list, do they list their, in their liabilities, how much they spent on 340B? I mean, so they're telling you how much revenue. Do they also tell you how much it's costing them?
no, just the only standardized line is revenue.
Questions for, Woody, did you want to ask your question around administrative burden to the
I think you
board?
mentioned that if they have to go into some sort of analysis of the data, then they might require additional staff. If I understood what she was saying.
Yes, I will say that as part of Act 134, which is looking at the options for regulating prescription drug costs and affordability in Vermont, the 340B program is just one of the areas in which we are looking. We in a more comprehensive manner, we will be providing final report with recommendations next year to the legislature, and that would include an analysis of the most likely, the recommendations that we would have that would be most beneficial for regulating prescription drug costs that wouldn't result in, a burden. So the best bang for our buck kind of thing. So this is part of that. I do think that right now, as it stands, collecting the data would be an added burden for hospitals, not so much added burden for the Green Mountain Care Board. Again, the way the bill is written, we're posting the reports that are provided by the hospitals. If we're asked to do analysis and certainly any kind of regulation related to that, then yes, then we would have to look at how much staffing would be required for that.
Would having this data help inform your work in the position that we created around prescription drug affordability?
It certainly would. I know that other states collect this or similar data, which we're looking at to understand what the impact of the 340B program is, and any and all data is certainly going to help us.
Okay. No, did you?
Yeah, not to interrupt, apologies. I'm trying to wait for the lag. To go back one moment, I just want to fully answer your previous question. I pulled up an income sheet here. So to confirm about the data that the hospital budget process collects, we have a line item for 340B revenue. So that's revenue designated only as 340B. And then we have an expense line for all pharmaceuticals. So that includes 340B, but it also includes inpatient drugs and other things. So there's no way at the moment to compare apples to apples. income and expenses.
Great. Thank you. Thank you both. And Charlie from Healthcare Advocates Office.
Hello, how's everyone doing? Hi. For the record, I'm Charles Becker. Most people call me Charlie Becker. I'm a staff attorney with the Office of the Healthcare Advocate. Been with the Healthcare Advocates Office for 3 years. It's an honor to be an advocate for affordability and access of healthcare for Vermonters. It's also a joy for me to be able to, as a part of my work, spend time really digging into pharmaceutical pricing. I think I spoke to this committee last year about my personal experience as a person with a chronic illness who relies on expensive medication to stay healthy. And it's been a very strong interest of mine to try to figure out why are pharmaceuticals so expensive. And now I get to do that as part of my job. So one of the things you learn about when you're trying to figure out why drug prices are the way they are is you encounter the 340B program. And so you've heard testimony over the past day and a half already about the 340B program. In its simplest form, covered entities buy drugs at a low price and then sell them at a high price. The result being a margin, some might call it a spread, but it's a little pot of money for each 340B transaction. Multiplied by however many thousands of drug transactions a covered entity may fill per year, and that little pot of money becomes a big pot of money, which is intended to stretch scarce federal resources as far as possible to reach as many patients and to provide as many services as possible, as we've heard multiple times over the past couple of days. And that's a good thing, right? We want to be able to stretch those scarce resources. But what happens when you have a big pot of money is that a lot of people take an interest in it. And that's what you've been hearing about over the past day and a half. Lots of voices expressing positions about 340B revenue. None of which is to say that 340B is good or bad. I think you did hear multiple witnesses saying yesterday that if they were to design an ideal healthcare system, 340B wouldn't be a part of it. And I'll add my voice to that chorus. But 340B exists in this imperfect system that we have. So I'm here to talk about H202, but to quickly touch on 266. Whatever this committee decides to do with 266, and I do think you've heard some really good testimony over both days, presenting both sides of the story. And I will say, and it might be controversial here, that the pharma lobbyists, the point of view that they presented was not unreasonable. They have a reasonable point of view. But the financial condition of our Vermont providers, on balance, is probably more important. And until there's a federal fix to the program, the contract pharmacy protections, at least, in H266 make sense to the HCA. I know there was testimony, I think, this morning from MVP about some of the payer language in 266. That might merit further investigation, but the contract pharmacy language makes sense to the HCA. At the same time, you've heard testimony about how big the 340B program has gotten. Just knowing how big that program has gotten is the number one reason why I think we need legislation like the transparency language that's in Section 3 of H202 that you just had a walk through from Ledge Council and that the GMCB just spoke about. Simply, when you have a large sum of money at stake, and in Vermont, I believe 340B revenue comes in certainly the tens of millions of dollars a year across all of the covered entities, probably over $50 million a year. When you have that large of a sum of money and multiple actors who are not providers of healthcare, like PBMs, third-party administrators, vertically integrated chain pharmacies, which arguably they're providing healthcare. But when you have for-profit interests seeking to get a share of that 340B money, you know, it's probably a good idea to have as much insight into that program as you can possibly get. And right now, we don't have any transparency at all into the program. Only 2 states have passed language similar to what's in Section 3 of H202, Minnesota and Maine. And as you heard yesterday from the pharma lobbyists, Minnesota has already issued their first report based on the data that they obtained from a language that is very similar to what's in H202. Of the Maine and Minnesota models, H202 is closest to Minnesota. And Minnesota has their first report up. It is very interesting and eye-opening, and you can simply Google Minnesota 340B Transparency Report, and you might see the kinds of information that we would get here in Vermont if we passed something similar. What reporting would be most helpful? I mean, there's 9 or 10 subparagraphs in this section. Certainly thankful to the GMCV for bringing their thoughts for improving that language to the table. I think what they've suggested are great improvements, would make the reporting stronger. I'm certain that with further testimony and discussion amongst this committee, you'll find the right spot, the right reporting that would be helpful to the state of Vermont. But just, 202, Section 3, where we're at, is a good place to start. And the HCA hopes that there is some movement towards 340B transparency here in Vermont. I think it would go hand in hand with giving the FQHCs and hospitals and other covered entities, giving them unlimited contract pharmacies, but also getting us a little something back, some data, some information about how this program is operating here in the state. I'm going to pivot quickly to Section 4 of the bill. I mean, that was my testimony on Section 3. I maybe should stop and see if there are any questions.
Any questions for Charlie?
Are we gonna get it right?
I could provide this in writing, yes.
Please,
Okay.
that would be very helpful. I can't keep notes.
Okay.
Do you have any information or experience, or have you had any discussion with hospitals or insurers from Minnesota about their experience?
I have not. And that would have been a good bit of research to do, but I have not. And certainly I could, and it's good homework to follow up. Yes.
Too.
Yeah.
Can I? I just found this Minnesota report.
I was looking at it.
Yeah, so could we get that on our website? I think that would be.
If you just send you a link. for it.
Yeah, that's great.
All right, you want to?
Okay, yeah. Section 4, yeah. As you heard Ledge Council describe, Section 4 would require 2 types of disclosure to Vermont consumers. I'll start with the second of those disclosures, which I guess would be in paragraph B of Section 4. This paragraph would require 340B covered entities to once per year notify patients if drugs that were prescribed by the covered entity were purchased through the 340B program. Why is this something a person would want? I see the question coming already. I would say this is about transparency. To go back to H266 for a second, the other bill, there's language in the bill's summary that says the purpose of H266 is to protect 340B covered entities and 340B contract pharmacies and their patients. Language is in there. Then goes on in at least 3 other locations in that bill to refer to protecting a patient's choice to receive drugs from the 340B covered entity or a 340B contract pharmacy, which to me seems like a weird thing to be protecting, to say that we're protecting patient choice when patients have no idea that their healthcare is involved in this program. Section 4 would address that lack of transparency to the consumer. Would some consumers be confused? I think we heard testimony this morning that there's a concern that consumers would be confused. Maybe some would be. Would hospitals need to open up a separate helpline to answer questions? I think that's doubtful. Would some consumers find meaningful information in that disclosure or be inspired to learn more about what's going on with their healthcare? I would say, I hope so. I think when consumers are more informed about what's going on with their healthcare, the system works better. The other disclosure required in section 4, that's at paragraph A, would require health plans to annually provide an accounting to individual beneficiaries of actual drug spending. As Representative Cordes testified when she introduced the bill last week, for medical claims, you get that EOB that tells you accurately what the healthcare provider charged, what the discounts were, and what your health plan actually paid out on your behalf. That's not strictly the case with pharmaceutical claims. It may be that you get an EOB, or if you log into your portal, you'll see some sort of processing of your pharmacy claim. But the best you're going to get when you look at your pharmacy claim in that member portal is an indication that there was some discount off of the full price of that drug that your health plan negotiated on your behalf. But we all know with prescription drugs, especially brand name drugs, that those upfront discounts are only a part of the story, and that there are rebates and other discounts that health plans receive after the fact that significantly reduce their overall drug spending. So significant are those savings from post-claim adjudication rebates and discounts that health plans vigorously defend them. Last year, this committee briefly entertained the idea of point of sale rebate pass-through to consumers. That was a part of the PBM bill. It was briefly a part of it. The health plans vehemently opposed that language because any concession of rebates to consumers would, in their opinion, lead to increased premiums. And opinion is probably not the right word. By giving up some of their rebate to consumers, there would inevitably be some push, upward pressure on premiums. I can't say how much that would be. And in this environment we're in, okay, we all get it, that any upward pressure on premiums is something we really can't have. But if you can't pass through the rebates and discounts to the person whose illness has generated that rebate and discount, at least tell them that you got it. And tell that consumer how much you actually spent on their care. You know, there's something that any person with a chronic illness might relate to. It's you do log into that member portal and you see how much they're saying has been spent on your care, $250,000, $500,000. And you think to yourself, well, first of all, can that really be? Is it really that high? And second of all, you think to yourself, man, that's a lot of money, right? It would be great to know that total really wasn't that high, and to really have an accurate accounting of how much a health plan is spending on your healthcare and your pharmaceutical care in particular. And that is that's my testimony on section 4. Are there any questions on that?
Questions?
I can see where the confusion is. You can see where the confusion, I don't care.
Right.
If I get a stick, that's money. I don't know. I pay for insurance. I pick up my drugs. I think that's just going to lead to more confusion, more phone calls, and more probably misinformed information. So that part I can see. And the other thing is, we make it so complicated that all these people that have extra staff, their profit's not going to be there. So in the long run, what they're spending it, if they're spending it on what they say they are, that's going to change. So
all fair points. I mean, yeah. I don't want to confuse people, and I know the system is very confusing. I certainly, it's not the HCA's position to want to cause consumers to be confused. And Mike might shut me down, but the HCA is also a resource for confused consumers. So yeah.
All right.
A question, but I also want to respond to that. I would say that, it's not this that would confuse people. The system itself is confusing. And we're trying to help educate people and, it would take effort. I would argue that, legislators would probably be one of the first first group of folks that people would reach out to. Probably not the hospitals. But to the burden of sending, we heard, I think it was MVP that said it would be burdensome to send yet another, like a snail mail piece in the estimate, the EOB kind of information. And so further discussion we could have what might be, would electronic means be acceptable? And where to go? I'd be curious about Minnesota and Maine, or Minnesota, what their experience was with that.
We should definitely dig in more to Minnesota and Maine. And I absolutely agree. And maybe there's language that we could come across that people receive their communications electronically these days. No one wants a piece of paper in the mail. So
Excuse me.
oh no,
Come on up my place.
I'm sorry. All right,
Either or.
Representative.
Yeah, I have a lot of constituents who don't have
Oh,
Many.
okay.
or email or.
I think the language would have to be however the member chooses to receive their communications, whether by mail or electronically, would be how this disclosure would be.
Which is how
Would be provided.
most businesses do it anyway. You
Mhm.
get to opt into electronic or snail mail.
I don't know if you know the answer to this, but Medicare currently sends quarterly explanation of benefits to all members, don't they?
I do not.
In the mail?
I know. Yes,
Okay,
LBAs.
okay. So this would be a yearly, basically be a yearly letter that would say you received drugs that were purchased through 340B.
That was the intention, a yearly notification. Yep.
Yeah, Leslie, question. I'm just wondering if the genesis of this bill, the writing of these two bills are based on the Minnesota bill or the Maine bill, or where's the origin?
Oh, let's ask the sponsor of the bill.
There's a personal genesis, which I think has already been mentioned by our witness, combined with a personal, for both of us, interest in helping increase transparency around the pharmacy, the drug market, and how much, identifying how much money is moving around where we don't see it. And so we have no way of being able to ensure that our precious healthcare dollars are being utilized in the most appropriate way. So I think transparency is really critical.
And if I could add on to that, is that okay? Yeah. So the transparency language specifically in section 3 is closest to Minnesota's transparency language, except that Minnesota requires reporting from all covered entities, where section 3 is limited to just hospitals. And I think the intention of that was to, most of the 340B revenue by volume is going to the hospitals. The FQHCs are smaller. They, it's important to them, the money, but they're just getting a smaller amount of it. The most of it's going to the hospitals. And so, I mean, just as a start, I think the thought was that we would require reporting from the hospitals.
Let's let Lizzie finish and then.
Yeah, I just read the executive summary from the Minnesota report, and it's really good. It's accessible. So it really helps explain it, just what you said, the big hospital, they have a ton of money, the FQHCs are getting tiny money. Everything is sort of summarized very nicely with just information.
All right.
Yeah, just, I really liked your comments in the beginning about, I don't think any of us are saying we want that, we're trying to make the 340B program go away. We're not. I realize and have been protective of the 340B program for hospitals, because I know what it's such an important program. So it is the system that we have. I'm not with this bill in any means trying to undermine the importance of the 340B program for hospitals and other healthcare providers.
Thank you. Thanks, Charlie.
Thanks so much. Thank you.
So we're back here at 1 o'clock.
We're done.
Yeah. Are we gonna try and do this before crosswalk? I'm just wondering.